So you'd think I've got the easy shout, but I'm now talking to parents and families and patients with leukodystrophies to a room of professionals that work in leukodystrophy. So we'll see if we've pitched this right by the end of the morning. So people use the term leukodystrophy really interchangeably with inherited white matter disorders, and I'll probably flip back and forth because I can't help myself during the presentation. But these are essentially genetic disorders, so they're not always inherited. They don't always come from our parents, but they do come from our genes, and they mainly affect the white matter of the brain. The brains are predominantly made up of our grey matter, so that's our thinking bits, to put it crudely, and our white matter, which are really more our messaging tracts. So they've got the bits of the thinking and the doing, and then we're going to send those messages down to our body to make ourselves do something, but also between the areas of our brain to help them connect and work and network. So white matter, what is it? It's called myelin, and this is the insulating sheath covering our nerve fibers. It's predominantly used to pass messages, but it's also really, really important for the health of the axon, the nerve fiber, the thinking bit system underneath it, because it helps to provide nourishment, maintenance, and repair for the nerve itself. So if you don't have your myelin, yes, you might not pass your messages along very well, but over time, the nerve itself underneath that becomes damaged. So that's why we see different phases in our children with leukodystrophies. So you can't put the myelin on, or your myelin becomes damaged, and later down the line, we get changes in symptoms because our nerve then becomes damaged, and we see that across different trajectories of diseases. And really, when I talk to families, I talk about the insulating plastic on your wires at home. If somebody nibbles your insulating plastic, your wire would not work very well. Now, you'd still get some message down there, but it might spark, it might cut out, it doesn't do it the way that you want it to do. And our myelin really works a little bit like that in our brains and in our nerves out to our bodies. So for some patients affected, these are primarily CNS, so central nervous system disorders, but you kind of get involvement of the PNS, which is our peripheral nerves out to the rest of our body. And there's a mix for different disorders, different bits of your nervous system are going to be affected. Now, it's more than just myelin. So it sounds very easy just to talk about that plastic covering, but even in the time that I've been doing leukodystrophy work, so 2016 onwards-ish, our understanding of the biology behind myelin is grown massively. So these aren't just problems with the way that the myelin itself is built, but that whole network in the nervous system that builds the myelin in the first place, maintains the myelin, does the metabolic processes underlying the myelin, and then other cells in the CNS and the brain that are involved in that network of keeping everything working and healthy. So we talk about leukodystrophies, white matter problems, colour changes that we see on a scan, but actually the biology behind that and the causes of that are so much more complicated. And there are some conditions where you can look at a scan and think, yep, we've got it, know what the answer is. But other times you're saying, actually, I can see the end result, but I need so many more steps to understand why that's happened. And I think in this diagram, this isn't the most complicated diagram, it's just a very nice diagram that shows you all the different cells within the brain and within the nervous system. And this is a spattering, not all of the genes involved in that, but you can see even on this how complicated and how many areas can be affected and how many genes, even for one area, you've then got 10, 12 genes that affect just that small part of the process. So it's difficult. It's difficult to understand from a picture, and then it's difficult to understand how it works. And we don't understand the interaction between all of these things. I might be able to tell you what gene causes it. I might be able to tell you what that gene does in one setting, but actually how it then does the rest of the cascade, we still don't understand all of that for all of our disorders. And in fact, probably any of our disorders, we don't understand the full pathophysiology as well as we'd like to. So myelin and white matter, we don't have it all when we're born. We make it really from the end of pregnancy, and our brains can develop white matter all the way through our lives, but the majority of our white matter and myelin is made within the first 2 and then up to 5 years of life. So if we did scans of our patients at birth, we'd see a very different picture to what we see at 2 years, and actually from 2 years through into adulthood, the scans are similar. There's still some myelination going in the background process, there's more to be done, but we see almost complete myelination by the age of 2 years. And that's important because some of your children, or when they're scanned when they're younger, say, oh, we'll do another scan. We need to think about when we're going to do that scan, because actually I want to think about your completion of myelination in a lot of patients, so we need to time that and think about the gap so I can look at what's happened in that time frame, where are we now, what can I predict for your future based on that. Now, we're using the word white matter disorders or leukodystrophies, but that's a huge spectrum. There's over 100 different genetically distinct things that I would call a primary white matter disorder, and they're different. So in some leukodystrophies, our bodies and our brains don't make enough myelin. It's very rare that you make nothing. People usually make something, but it's how much and the quality of that. And those disorders are our hypomyelinating disorders, and they present very differently. If you've never made your myelin or you've never made enough myelin to start off with, often the challenges we see are from very early on in life. We often see developmental delay, spasticity, eye changes, nystagmus, and movement disorders. And they are children that may have always had some degree of concern, and their trajectory changes over time. But in other disorders, our myelin is made, but then becomes damaged. Now, sometimes that damage is very evident very quickly. So as soon as you're out of the womb, there's evidence that something is going wrong, and we can see that problem. But for other patients, this happens later in life. So you can be well, your myelin is there, it's doing its job, and the maintenance mechanisms behind it have worked for a period of time, and then we run into trouble. And that's often because something else has accumulated, it's taken time for things to build up before we can see the consequence of that damage. And often these things present in childhood, but as we'll know from the room, there's conditions that present 40, 50, 60 years down the line before we've thought about them. And you've been well for that period of time. And that gives you a different set of challenges than from having a child that you've had from the off and always been worried about, to having someone that has done a period of life well and then had changes. Now, they're not, one challenge is not bigger than the other, they're just a different set of challenges. And it's important to know about that because we might support our families and our patients differently. It's trickier with that secondary group where your myelin becomes damaged because we describe them and call them lots of different things. So you may see the words demyelinating, dysmyelinating, cavitating, and what I would say might be slightly different to what another professional would say. What you see written down in one paper might be slightly different to what your doctor might call it. So it's difficult to be as firm about the classification of those diseases. So this is our brain scan. So this is an MRI scan. It's a T2, so when we look at MRIs, we look at lots of different ways we can put the pictures and the colours together. But on here, oh, is there a pointer? Hopefully I won't break things now. Ah, yes, excellent. So you've got on the outside, and there's some labels coming in the middle. So he's lying on the bed. So this is the bed here, looking at the ceiling. Ears would be at the side, so I'm not going to move the scan up and down. So it's somebody lying down, looking up. We see the front of the brain and the back of the brain. And when we have a look at our scan, we have our grey matter. So confusingly, all the different bits are not what they look like on the colours. So our grey matter is this, is the light grey around the outside, and then there's some more in the middle. Our white matter, which is frustratingly blackish. If I did this scan when they were 2 months old, this would be white, and now it's not. So when we get to adulthood on a T2 scan, this is the blackish bit. So you can see you're going to do your thinking out here, and then pass these messages to the middle of your brain, and then they'll go down your spinal cord to your body. So all these bits in the middle, so these black networks are your white matter. And when we get your myelin laid down from birth through into childhood, that happens in a set pattern. So when I look at scans, so we don't wait till you're 2 years old to tell you may have a problem with your white matter, because I know that at 3 months it should look like this, at 6 months it should look like this, and that myelination happens in a pattern, and I should be able to see it following the right pattern. And in some disorders, you get a very set pattern of what's not quite right. And then the other bit that we see on our scans, and often is confusing when we're talking about white matter, is these bright white areas. So these are our fluid spaces. So our cerebrospinal fluid, the fluid that's in our brain and also around the edges of our brain, are really bright white. So sometimes I'm going to show you some scans with some bright white matter in a moment. It's really tricky to get that, to make sure we're not thinking about fluid spaces instead. So now we can see a different type of scan. So this is our scan we've had a look at the top corner up here. And here we have our white matter, and it's not that black colour. So again, this is a scan. Both of these are scans at 2 years of age, but this white matter has stayed light grey, whitish. Oh, excuse me. And this is really a hypomyelinating disorder. So sorry, I can't quite reach the point over there because I haven't quite got the angle, so apologies. And you can see there probably is maybe a touch of myelin. Maybe I can persuade myself that you might see, but actually, almost exclusively, there's no myelinated white matter in here. So the white matter's there, but it's not myelinated. You've not got that insulating sheath on the outside of it. And that looks very different to some of our demyelinating or dysmyelinating disorders. So on this scan, we have that sort of what we describe as a normally myelinated white matter at the front, and that's still black. But then this dysmyelination at the back, where that white matter has become angry, aggressive, inflamed, and because of that, we then see this bright whiteness. And in these disorders, the colour change of the white matter will change over time. So we have really angry and aggressive white matter, and then we have change over time where you can see it's been damaged and it's not as acute. And then over time, if you've had big, angry, inflamed white matter, it can become reduced in volume. So when we scan our patients, we see different things. When we look at them on the outside, we can sometimes guess what we might see on the inside. Sometimes the scans don't fit with where we are with the patient, and you track that over time. What's the most important is to treat the patient and how they are, but the scan will give us information, and we don't do regular scans in the UK, so in other countries you have annual scanning, every couple of years scanning. We do a little bit more in adults because it's usually easy to get you through a scanner, but actually we don't monitor your scans so regularly in childhood particularly if you need a general anaesthetic, because actually I don't want to treat your scan, I want to treat your patient, and that's much more important. But if we do scans, they change and evolve over time. Sometimes it makes sense to me, sometimes it doesn't make sense compared to what I'm looking at. So these are not just rare diseases. These are very rare diseases. So they affect less than 1 in 10,000 people, so that's less than 0.01% of the population. So there's not many of them. But actually, when you add them up, there's lots and lots of different disorders within that group. So over 100 genetically distinct disorders. And that's ones I'm talking about that are our primary leukodystrophies, our primary white matter disorders. The number of things that affect your white matter more than that are into the hundreds and thousands. And we'll talk a little bit about those in a minute. But what's really important is, even though there's not many of you, the consequence on morbidity, so the disability, the dysfunction that you have, and the mortality, so the shortened lives, in our concept, and I'm talking in terms of children here, actually it's 25-30% of the childhood disability we see in our clinics. So there's not many people, but actually the impact on that for our families and numbers and what we see in clinic is really high. So it's serious, it's a really big problem for lots of families, lots of NHS clinics, but not everybody knows about it. So leukodystrophies are broad. I don't need to tell the room because all of you will have presented in your own way with your own story, and if I lined you up, you'd all look completely different. But for the majority, we make a sweeping statement that most of these conditions present in childhood. They're often, but not always, progressive, and sometimes if you meet the wrong doctor that gives you a diagnosis, they don't know that, because if you Google leukodystrophy, it does not look cheery. And many of them are life-limiting, but there are, even within the same diagnosis, I would have that discussion very differently with families. So there are some families where I'm quite brutally honest. Karen's been to some of my clinics. I think honesty, they're your child. You should know about what's going on. It's you. We should be honest. And sometimes we have to be really frank. I could see the same patient with the same, or a different patient with the same diagnosis. We have a different discussion. Even within your groups, you are different people, and that's important. But because of the rarity, the complexity, the difference between the groups, we're not very good at diagnosing them. So diagnosis is often delayed. Now, why is that important? Because actually it's frustrating, it's difficult, it's emotionally burdensome to not know what is going on. You have to have tests, you have to have more appointments, you have to have more scans. That's also quite costly financially. You have to travel back and forth to the hospital. But equally, every blood test is not an easy thing to do. Every scan is not an easy thing to do. So it's burdensome. But it also affects your access to specialist treatments, to specialist services, to trials. Now, I'm not going to pretend that we can change the trajectory for lots of our leukodystrophies at the moment, but you do deserve to know where things stand, what the lay of the land is, and what's going to happen in the next 5 to 10 years. And without a diagnosis, we can't always give you that information. And you often don't reach the right service. Even if I don't know the answer, I can take a punt sometimes. But actually, if you've not even got that far down the line, you've got even less information to work with. So the start of the concern about leukodystrophy usually happens at an MRI. Now, sometimes an MRI alone is enough. I look at an MRI pattern and I say, yep, I think I know what that one is. And we can say, just do this genetic test. But unfortunately, it's not always so easy. There's a real diagnostic challenge around leukodystrophies. So first of all, there are some suspected leukodystrophies. So I can't label you as definite, but actually you've got definite changes. It's not a specific pattern that fits one thing, but I'm pretty sure that this is a leukodystrophy or a primary white matter disorder. I can't label it yet. I can still talk to you as if you have a leukodystrophy, and I will say that. I can talk to you about hypomyelinated leukodystrophies, and as a group, they tend to do this. I can talk about a cavitating leukodystrophy, and they tend to do this. So I can give you some information, but I can't tell you exactly what it is. I can't tell you, for that spelling mistake in that gene, I actually also need to scan your heart, because these ones have heart problems, these ones have hearing problems, so I need to look out for those things. I can't tell you about your specific prognosis. I can talk about hypermyelination as a group. I could talk about the patient looking at them based on their signs and symptoms. But I can't tell you specifically for these group of patients, this is what you look like in 5 years' time. And I can't tell you about life expectancy. I can't tell you about your family members and family planning and telling you what is the next step, not just for you, but for your wider family. And that's really important. The second and probably the bigger complication, so apart from not being able to label the ones I think are really true, is all these ones that probably aren't true white matter diseases. So there are hundreds, thousands probably, of other disorders that also affect your white matter, but it's not a white matter disorder. So, for example, neurodevelopmental disorders, where children have developmental delay, learning difficulties, often their brains are sometimes built a little bit differently to mine or to many other children, or they're just a little bit slower in growing. So if we scan their white matter over time, they'd have some delayed myelination. Often over time, these disorders catch up, but not always. And sometimes they fully mature. So they affect your white matter, but the main problem there is not a white matter problem. But if someone's looking at your scan and they've got a little bit of change to white matter, you can very easily end up with the wrong label. Someone said, oh, a bit delayed white matter. Someone else might call that hypermyelination. You Google that, you've Googled the wrong thing, and the news is not good. And then there's other disorders. So if you're poorly on intensive care, that will affect the way your brain develops, what your white matter looks like. Sometimes that's acute, and sometimes it's a little bit longer lasting. You can have damage because you've been so poorly. You can have hypothyroidism that affects the way your white matter is built and put together. If we treat it, that often gets better, but it's later. So we need to understand what the problem is, what age of life you're at, what part of brain development you're in, and how real we think their problems are in terms of a leukodystrophy white matter diagnosis, so we can then investigate, advise, look after you properly. And then the final complication, in the many complications on this list, is about acquired and non-genetic white matter disorders. So in our MDTs, every week, or every month, most people do them every 2 to 4 weeks, we see scans of patients who have really frank, big, bright white matter changes, white bits, black bits that shouldn't be there, but they're not genetic disorders. These are acquired disorders, so things that have happened because of something else in your body. And the most common cause of those changes in the adult population, at least, is multiple sclerosis. But actually, there's loads of other disorders that affect your white matter, but are not genetic white matter disorders. Now, often we get clues on the scan. So some of the pictures of the scans I showed you, we have big change, bilateral change, symmetrical change. And often our acquired disorders are a bit fluffier, a bit patchy. There's bits that look brighter, bits that look lighter. Sometimes we can't tell. So there are clues, but sometimes we don't know. And we have to, based on our experience, say, I think you're going to be in this group, I think you're going to be in this group, and then tailor our investigations. But it is difficult. And that's what, I'm biased. I'm a neurologist that looks after people with rare disease. But that is why I think rare diseases deserve specialist attention. If this was me coming, or my family member, or my father, my son, I'd actually want to know whoever's looked at that scan can really tell you what they think is going on. I don't want to give a misdiagnosis because I've had that in my patients in my clinic, but the consequence of being told you have a leukodystrophy when you don't have a leukodystrophy is probably one of the biggest problems. I'm talking to a room full of people that have lots of challenges in their life, but actually it is a real emotional burden, and some people never get past that. I've undressed several changes, and I think particularly in I'm going to speak for my adult colleagues, and I might be wrong, but conversations with my adult colleagues, they have a huge amount of things that are labelled one way or the other that's not correct, and actually if you Google that, the consequences are significant. But not only do we think it's real, but what is it? What tests do we do to sort it out, and how urgent is that? We can't treat all of our disorders, but there are treatments, there are trials for some conditions, and actually, I don't want you to wait a year for NHS testing to come back. I want you to find that answer out within 2 to 4 weeks, because then I might be able to do something about it. And some of these disorders are treatable only in the early stages, so you need to crack on and do that. We want to provide expert support around diagnosis. These disorders are so rare, loads of doctors will never even have heard of them. So actually, when you get your diagnosis, you want to have the experience in front of you to be able to ask questions. What does this actually mean? Not Wikipedia, Google answer, but actually for my child, for my patient, for my parents. When you look at them, how do you interpret the genetic result? Can you tell me about my risk factors, my prognosis, my life in future? And yes, we don't have a crystal ball, but from experience of looking after lots of families with those conditions, we can be more targeted and tailored, and that helps you understand where you are. And then there's guidance and treatments and trials, and I hope that in the next 5 to 10 years, that aspect is something that is the bulk of our work. We're not there yet, but we're coming to it. But every time I see a new patient, I have to get online, look at the clinical trials network, what's opening, what's recruiting. Any doctor can do that, but even for me, it's hard to know where things stand, and I want to have accurate information when people come in the room. We are, as a network, much better at being fore-informed, if that makes sense. So in fact, companies are coming to us. Meetings like that mean, even if they're not up there yet, I tend to know what's coming, and if I don't know, I do know who to ask. So sometimes you know there's something on the horizon, but I don't know who can quite reach it, where it is, what stage of planning are we on for that trial. Actually, even if I don't know the answer, I know where to get it from. And that saves you going to your doctor then doing some digging, may or may not have the right information. We need to prepare ourselves as the landscape of treatment changes so that we can then prepare and adequately inform our patients. The other thing about this that I think will be covered over the course of the weekend is not every treatment or trial is right for our patients. Just because we can treat some disorders, we shouldn't necessarily treat all of them. Sometimes treatments are burdensome, sometimes they are risky, and I'd love to say that every treatment we give works. It doesn't. And sometimes the treatments we give work really well in one subset of patients, but they don't really work well for somebody else. And if you're going to make decisions about using a treatment that is risky or burdensome, there is some disorders where you have 2 weekly infusions, injections of something, you want to know that it actually, for you, for your patient, for your family member, that is going to hopefully give you some benefit. Now, some people will always take the treatment, but actually, for a lot of my families, I have found lots of families that say no, because this is about quality, it's about what's important for that family, and not all of our treatments fit into that group. So, I've spoken, I don't know how long I had, but hopefully I've not gone too over. We'll see. In summary, leukodystrophies are primary diseases of the myelin, the insulation on our nerves. They're genetic, so caused by spelling mistakes in a wide range of genes, and they are very rare, meaning that not all doctors will have heard of them. They're heterogeneous, so not all patients look the same, so you can have the same spelling mistake that causes the same condition, and you don't look like the person sat next to you in a clinic room. And we have to remember that not everything causing white matter changes on a scan is a leukodystrophy. And if we're going to talk to doctors that don't see leukodystrophy very often, that is the message that we want to pass back, is not everything is the same, and we want to tailor what we do for our patients. So there are specialists around in every ilk of the world, so from pediatrics through to adults. If people aren't sure, they should be asking. And as patients and families and parents, you are entitled to ask. There are people there to support you, and if your local doctors can't tell you, you should be getting that information from other people and supporting you in person or sometimes remotely with advice. Fabulous. Thank you ever so much for listening. If there's any questions, happy to try and answer them.
Thank you, Dr. Green. That was such a good presentation, and
maybe on time.
Yeah, I think it kind of helped. Has anyone got any burning questions for Dr. Green? If not, you can always grab her over the weekend and. Oh, okay, yep. Yeah.
Would you agree immune system understanding in rare leukodystrophies is extremely limited? For example, my child takes daily antibiotics, which explains that immune disease is compromised within this disease, but reports of pediatric deterioration and death caused by metapneumovirus. I'll try and be accurate. So I think you're right, I think we don't know a lot of things. So there are some leukodystrophies we definitely know have an immune relationship within them, but even the ones where we know that, we don't necessarily understand it. And I think some of the challenges in the diseases where we know more about the immune interaction is people can then become very overconfident as if we target the immune aspect, then we can fix all of the problems. And actually, there is definitely some modulation within that, but the degree to what has happened in terms of the preceding damage, we can't always change. So there's disorders where we know there's some immune involvement and how we manage that. And then even in other disorders, so in terms of I'm making assumptions from the question, so apologies if I've got it slightly wrong, but one of the across the spectrum, problems with our children is if you have disability, you have vulnerability. So there are some leukodystrophies that cause the end of life and will cause our children or our adult patients to pass away. But actually a lot of the end of life for children with leukodystrophy or adults with leukodystrophy comes because of the complications of disability. It's not the disease that causes the problem, it's the vulnerability to all of those other things, and therefore the illnesses, the chest infections. So that's not necessarily related to the disease, but it is something that we can try and modulate to protect our patients. And so perhaps if you've got antibiotic cover, so I treat some of my patients, not everybody, have antibiotics over the winter months because I can't treat their disease, but I can manage that aspect of them that makes them more risky. So therefore it's not necessarily immune relationship to the disease, but it is protection and treatment in a different way. I don't know if that answers the question on here, but hopefully I've had a good enough punt.
Thank you.